move this. And if you can move this, I mean, otherwise, my laptop is, the length is only so much.
Okay, what you want? You want to make it turn here?
No, no, this, if you can move. Because I'll be standing here
Okay,
most of the time.
remove this, no?
And then
This has no use.
move this to the side. That's good. Okay? I don't. I'll stand here only. I am okay. I can just change my slides. Huh? Okay. So, what were the topics? I heard him say.
Pediatric candidacy and adult
Correct. So two aspects we will discuss today. One is pediatric candidate. So the whole topic is about cochlear implantation, right? So in cochlear implantation, what we will cover is pediatrics also as well as adult cochlear implantation. So one thing is before we get into pediatric cochlear implantation, we will look at how, what is the importance especially in early intervention in children. Now one reason is we want good outcomes. How do we get good outcomes? What are good outcomes? Good outcomes means the child should be able to like like correct. So our what we as professionals want is any child that is born with a severe to profound hearing loss. What's our aim as professionals? We are constantly trying to think this child, in spite of his profound hearing loss, how can he perform like a typical hearing peer? Is that right? So we all want those kind of good outcomes. But what we are going to discuss now is how are those outcomes possible? Is it possible, and what we need to do in order to get good outcomes? Okay, so for which, instead of talking about hearing loss, we are going to look at how it's about the auditory brain development. It's nothing to do with the ears, it's nothing to do about the cochlea and the hearing loss. We will now focus about how the auditory brain and the development of that is very important. If you start counseling a parent or a professional in that aspect, the way they start to look at hearing loss changes their perspective. How, what will happen to them? They will understand how critical it is because it's the brain development and nothing to do only with the ears or only with hearing. Okay? So with that, my first question to all of you is, give it a thought. When do we first hear? When does our hearing begin? In the womb. Perfect. So, yes. So, we have to start talking that hearing has begun as early as 20 weeks in the womb, right? So, not at birth, where majority of people think it begins when the baby is out of the womb. Hearing has started when the baby is in the womb. So, what we need to understand, two important things here. Whenever we are talking to families, they need to understand two things. That cochlea is formed and the connections are already formed between 10 to 20 weeks. And the functionality of the cochlea is already started by 20 weeks. So, if the baby is born full term at 40 weeks, how much hearing they had? 20 weeks within the womb, right? So, functioning of the cochlea has started at 20 weeks. Baby is born at 40 weeks, so the hearing has already started in the womb. So what is possible at birth? You can start doing testing at birth. Therefore, newborn hearing screening is possible, and you can also do BERA or brainstem responses even in premature babies as much as 15 weeks premature. So one thing is, because the development has already occurred, hearing is now possible at birth, right? Hearing testing is possible. So your first message to anyone that you see, any parent, they should know that hearing screening is possible. because they are going to then tell others that, you know, screening is possible, then why wait or why waste time? Okay, so that is one thing. The third thing is, all of you also need to stress on the importance of, it's not about just hearing. After hearing, the next important thing is to process and understand the information. So just hearing is access to sound. What do we do to that sound? We try to understand, it's in our memory. So there is something which is beyond hearing, which is listening, and they will understand that listening takes place not in the ear, where? Correct. So now they are understanding that there is not only about one structure here, it has a relation to the brain as well. And then that connection with the brain is also demonstrated when you speak. So when most families want their child to speak, they have to be told that speaking happen when hearing comes first, listening comes, and then comes speaking. Can only speaking happen? No. So this is how you are joining the dots, and then they are trying to understand, yes, early hearing, listening is important for talking. Okay. Now we are born with how many brain cells? 100 billion. But what happens to these cells or neurons? They need to form connections. How are these connections formed? Correct. Exactly. So they are formed because of exposure to senses. Which are the senses? Vision, touch, smell, and similarly hearing. So remember, parents need to understand that even the even they need to understand that these connections, for these connections, early input through hearing is very, very critical. So they don't just form. Can they form automatically connections and circuits? No. You need to give the input. So when does that input need to happen? It is very time sensitive. It has to happen maximum between 6 months to a max of 2 years. So now they are understanding, oh, that is why it is so important that I don't wait and I don't waste time going here, there, doing this, because I am losing time on forming those connections. Okay. If those connections are formed, what will happen next? Once the connections are formed, that area in the brain specializes. That area in the brain, correct, starts to grow and it will become into a function. That's how we develop language. That's how we develop memory. That's how we develop hearing. Okay. Now let's look at what happens if that input is neither there or it is reduced. So what will happen? Correct. So they will instantly understand no input, poor connections, or there will be lack of connections. If there are lack of connections, what starts happening? There is no connections at the level of the brain where there was no auditory input. So the area where the hearing was did not develop. And because of that, the pruning happened. You did not use it. So this time, what will overtake it? The visual cortex. So they are understanding that as a parent, they first need to understand that for these connections I needed to give the auditory input. If there was no auditory input, then the auditory cortex will be overtaken by the visual cortex. So how do we know on a day-to-day basis if the visual cortex is overtaking the auditory cortex? Correct. So when a child has started to use lip reading and a child has started to use gestures, it should be giving us a sign that that deprivation has been so much that now only this part will start taking over. Okay, so it has already gone to the level where visual cortex has now started to overtake on the auditory cortex. So always remember, for this development to happen, the input needs to come in. The input comes in, this area will grow, specialize, and that function happens. Okay. Now, also the two comparisons between a child born with a hearing loss and a child with typical hearing, they don't start at the same starting point. Why? Because this child had 20 weeks hearing in the womb. This child was deprived of 20 weeks, which was there was no input during that. So can we call them that they are the same level? No. For this child already his 20 weeks delay is pre-existing. So always look at that plus the loss that he has after birth. Okay. So take that into consideration that the two children are never the same. The deprivation is always going to play a role. Okay, now you have to remember something, that it's all about the brain, that if there is delay, which most often the children spend lot of time going through lot of different centers, lot of different tests are done. So there is a delay in hearing stimulation, or there is a reduced input. That means even if we put a hearing aid, or sometimes we are not able to give them enough amplification. So if it is reduced input or there is a delay, always remember the loss that we are, or that time that is there and the development that is going to be affected is permanent. We cannot go back and change it. It's irreversible. And those neurons, there is no way they get reassigned for hearing cells. So you have to always look at this, that these damages that are done because of deprivation or lack of stimulation is permanent. So no bright therapy, no technology, nothing will be able to replace that. That is why it is called time bound. So there is only a limited window of time during which babies can catch up to their hearing peers. So we have only one golden window. If we don't do within anything within that window, we know that that loss or that impact on of hearing loss will last forever for that child. Therefore, hearing loss in babies is considered as neurodevelopmental emergency. Why is it termed or coined as neurodevelopmental? Yes. So, we should stop thinking that hearing loss is only to do with the function of hearing. It has a big role in the auditory brain development and all other related functions as well. Reading, writing, literacy, memory, all of those aspects are going to be impacted. So, start looking at, instead of looking at the ear, start to look what that ear is only a doorway. It's only like a entrance, but the main thing is your auditory brain that you are looking at. So, according to science, it says those neural connections should happen no later than 6 months. Why is this been highlighted of 6 months? Is because of the JCI guidelines. What are guidelines? That what the committee has found is that if we are able to screen by 1 month, why? Because we know hearing is all developed at birth. So second day you can screen. You can know if it is a pass or if it's a refer, if it's a outer hair cell or not. You screen by first month, which is possible. They will come back for vaccination also. Why can't we specialize in screening? Because that's our domain, right? So why only do assessment? Why not go into a lot of hearing screening? So hearing screening followed by identification. You have 3 months. By that time, even if there is a maturational issue, most of the times by 3 months it should be sorted. And by 6 months, you should at least know whether that child has what type of loss, what is the degree of loss, and whether what kind of intervention you would like. We are not saying that he should be operated at 6 months or something. We are just saying intervene by 6 months. Okay, that means input stimulation should start as early as 6 months. That should be the goal. I know all this sounds very good on slides and presentations, but we have to strive for something at least one step at a time towards whatever you're doing. So if you're seeing a kid now who is 2 and 3, you should think, what can I do that he is not further wasting any of his time? This is his critical time. There has to be something, his brain is going to be permanently otherwise having that delay. Okay, so start looking at that way. So hearing aids which you fit or even cochlear implants are good brain access tools. Okay, so it's not that we do only intervention, but they are actually going to help the development of the brain. So what is this reflection or resemblance of this ambulance? What does it mean? Why do you think how this ambulance relates to hearing loss? It's an hearing loss is an emergency. So what happens in an emergency room? Everyone's focus is only those who are there, saving the life, and only the main people, they look at it, that time is of importance, right? Everybody who is critical is involved. The rest of them say, no, we have nothing to do with this, we will not do. So the resemblance here is, you have understood the importance of early intervention. Now it is your responsibility to go back and equip your department, your team, whoever, wherever you work, needs to also think that this is very important, critical for that particular child. They cannot afford to say, it's okay, come 1 week later, 1 month later, we'll see after 1 year. No, because now we know hearing loss, whatever the deprivation is going to be a permanent one. Okay, so therefore when we look at ambulance, we are just saying we need to act fast and we have to act now. So which means early screening, early identification, and even intervention. So trying to avoid as much delay is what we are trying to do when we talk at emergency. So optimal intervention for hearing loss in babies is time bound. That means we cannot take our sweet time. No, today he is not cooperative. No, today we have too many appointments. No, today. So it's every time, every minute is very critical. And a child with hearing loss is starting from a neurological emergency, because learning to listen, we have seen, is time bound. Okay, so that is very, very critical. Whatever I have discussed so far is not Cochlear's view or what I feel is important and you should know. You will see that this is what you can highlight to any parent, any professional, whether it is a pediatrician, you work at different setup at your institute, you can start looking at this, that yes, I am looking at this child from a neurodevelopmental perspective. I am not just a sensory hearing loss or a sensory neural hearing loss. Now that we are doing intervention, and we suppose we try and do intervention only in one side. So can one of you read what this says? Just loudly, if one of you can read what is written on the screen. So what are the key words here? What are the important words? Correct. So one word is with unilateral stimulation. What will happen? The auditory cortex. So we think we have done great work. We have given stimulation. But if we did input only on one side, that brain will again reorganize, because stimulation has happened only one on that particular side. Like we know those synapses and the ipsilateral and contralateral, only that particular pathway will get stimulated. So what does this, the second line, mean? So if you have to put bilateral inputs, the question that we are trying to answer here is there a sensitive time period? Is there a window within which you need to do anything for putting sound into the other side? So We may be doing something only with one side, but that doesn't solve the problem. So we have to look at what time frame are we intervening in babies or even in children. What's the gap between when you do intervention on this side and this side? So what do you think, by what time frame you need to try and get the second hearing aid or implant on the other side? So age wise, by 3 years. Why? Because he looked at that critical language period. He says we saw that 2.5, 3 is critical language acquisition period. Any other answer? 5 to 6 months. So right now, that what is science showing us? So you all know about cortical evoked responses, right? So beyond brainstem, we can look at cortical responses. So if we implant children simultaneously, so I'm now talking about bilateral cochlear implantation. If we implant them right and left at the same time, you will see the cortical evoked, the latencies. What is latencies? Latencies tell you the maturation. How is that auditory pathway maturing? The rate at which it is maturing. So you will see that the both will kind of overlap, the right and left, if they are bilateral simultaneous. Okay. If you try and get them the implant within the first 6 months, like he has said, it is still considered, or you will still see that the synapses on both the sides and the latencies kind of overlap. And like he said, the second window, if you don't get that second implant within the first 6 months to 12 months after the first implant, at least try it before the child is 3.5 years old. So now we know that children who have got their first cochlear implant, one cochlear implant, when they should get their second one? Within 6 months for best results. And if that is not possible, by around 3, at least before that, below 3.5 years. Okay. So sometimes in our counseling, we tell the parents, no, you should go for bilateral simultaneous, but it becomes very difficult for them to manage the funds for 2 implants, right? So in that case, they can first get the implant on one side, which is where they can get the best technology, best implant, and then they can plan the subsequent surgery within 6 to 12 months to get the still best outcomes what they would have got. So time for unilateral and bilateral is very, very critical. The first thing, if you look at factors for affecting outcomes, so we started with the topic of outcomes, right? We said we want good outcomes, means they should have good language, academically do like any other child. The first thing, the first biggest factor is at what age they got that intervention. That is determining, that gives about 70% of your outcomes will depend on what age they got the input in. Okay. So now I will ask you another question, which is, how early do you think should we implant? How early can we implant? Or if a parent asks you how early is early, can I implant at 3 months, 6 months, 1 year, 2 years? What would be your answer? Sorry, very good. Excellent. Can we all clap for him? Very good. So one, he is updated. So he knows what are the recent guidelines. So like he said, earlier guidelines were about 12 months. And do you know where the 9 months FDA guidelines came in from? Is this particular study. So now what I'm sharing with you today is more updated information as to what are the guidelines, that what is the right time for cochlear implantation, okay, in children. So all of you know National Acoustics Laboratory. Everyone knows what NAL research does and how great research it is. So they did this research. So it is funded. It is nothing to do with Cochlear. So this is their government funding them to do this particular study, which is in the world considered very outstanding study. And we'll see why it is outstanding. So it is called longitudinal outcomes of children with hearing impairment. What is the acronym for that? It's called LOCI. Okay. Some of them call it LOCI, some of them call it LOCI. So it's up to you. It depends on what your preference. Um, you will see this on this YouTube. It says how early is early. There's a question mark. And then there is this loci study. This is available on YouTube by Dr. Teresa Ching. So she's the researcher here. It's a 12-minute video. You can watch it whenever you get a chance. It's going to summarize their whole research project for you, okay? And it's very good for professionals. And I'm going to simplify that today for you. I've already told you about 136. If there is any scope for you, at least somewhere in your department, try. If you don't message this, nobody will a ENT put this message or a pediatrician. So somewhere you have to constantly say, we are the hearing experts. We should do screening. Can I get involved in hearing screening in some way? So hearing screening is another very important domain if we want to get into early intervention. So it's not, my message to all of you is cochlear implants is the end result. If you want good results, start with hearing screening first. This will bring you to the intervention part, which is cochlear implant. So we are not talking about implants. We should talk about these two segments before we talk about this. So even Cochlear, we've been here for last 15, 16 years. Cochlear is in India. We tried to do this, but now we realize that if we don't focus on this, we will not get best results. So don't get into cochlear implants because it's intervention. Start your journey with screening and diagnosis, and then you'll have intervention as an option, okay? And we are not saying screen babies because we want children for implant. That is not the objective. If you do hearing screening, speech and hearing, even the family knows about hearing and speech right at the onset. They will be able to share it with their geriatric people in the family, and they know for speech and hearing you are the subject matter expert. So you don't have to worry how does audiology become, how do we drive awareness. If you just have to do hearing screening, which makes people aware that hearing and speech profession does exist, okay? So hearing, like I said, screening, the objective is not to get cochlear implanted children. Not every child who will go get referred becomes a candidate, but it just helps you with that whole process of identifying the right children and being able to support families. So let's come to loci. Loci study is trying to look at, does newborn hearing screening improve outcomes of children with hearing loss at a population level. So it's not about a small number of group of patients. It is a population study that they did. It looked at what are the factors. What factors? Maternal education, socioeconomics, cognition. What are the factors that affect outcomes? And can early performance predict later outcomes of children with hearing loss? So can we, is there something which will tell us how this child will do post cochlear implantation? So when I said it is population based study, I'm talking about this happening in the year 2005. They had about close to 472 children that got involved in this particular study. These are 3 different states, okay? So think Maharashtra, Gujarat, and this particular state. So you have different set of children and population, right? So they looked at 3 states and they involved children with good mix of boys and girls. Now remember, 40% of them had an additional disability. What does that mean? That means you may not necessarily see children with only pure hearing loss. They will have either cerebral palsy, delayed milestones, some kind of learning issues, and they also saw a small percentage of cases with auditory dyssynchrony. Okay, so that is the population that they covered. Most of the time, I said we look at outcomes. So here they looked at outcomes, which was not speech, language, hearing outcomes. They looked at whether what happens to these children when they grow up and do they get employed or not. What are their educational qualifications? How much can they study? Can they become a doctor? Can they become vocationally trained? What happens to quality of life, mental health, and cost effective? Is it a good intervention, cost effective intervention or not? Okay. So between children who were born between 2002 and 2007, we are right now in 2023. Now these children who were born between this, how old do you think these children are now? Yeah. So imagine 50% of these children had their implant at 6 months of age. Now we are not even implanting children at 6 months, but in 2002 and around that time in 7, these children had received their cochlear implants, okay, at 6 months. So what NAL is able to do, or that local study is able to see, is this child or these children, 53% of children, they are trying to look what is happening to this child when that child is growing, goes to school, goes to university, gets employed. Constantly they are comparing that child to his hearing peer and trying to see, has he matched, or are there still gaps? And from that they are able to say whether early intervention matters or not. Okay. So 163 children out of the 468 had a cochlear implant at that point of time between the year 2002 and 7. Okay. So these kids, like some of you have said, are close to 20 years old now, and they were implanted very early. Now, why is such kind of a study possible? Because there is uniformity or standardization. So, even if different states were involved, you know, there is Australian hearing services that follow same guidelines and same practices. So, no, if this audiologist X and this audiologist Y fits, they'll follow the same protocol. So there was no difference in methodology, and that is why such kind of study is possible, because of the uniformity and standardization. So like I said, these children were looked for outcomes at 6 months, at 12 months, when the children were 3-year old, when the children were 5 years old, at 9 years old and 16 years old. And they have been able to publish the data at 3 years, 5 years, and now they are going to publish the 9-year data and outcomes of these children. So your question will be, what kind of data do they present? That how these children are doing in language, in literacy, in academic and social outcomes. So they are looking at the child from all aspects, how they are able to perform. So we wonder what test or tool to use to measure outcomes, right? So look at, these were the measures. For receptive language, they used the preschool language scale version. So it is called the PLS. For expressive language, again the PLS was used. For reading, there is a reading test battery. For mathematics, letter knowledge, speech production, behavior problem. So these were all the outcomes that get measured. When? 6 months, 12 months, 3 years, 5 years, 9 years. So every time the child comes, they get tested for this. Now, after testing, different types of tests are there. Some of them are through direct assessment and some of them are through parent report. Why? In young child, how can you do direct assessment? So until they develop language, you need to do parent report. Again, different tests, different scoring. So what was done? All these scores were converted into one single score. That score is called global language score. So instead of having one test with 50 out of 100 or other one which says 100 out of 100, they were all converted into one single score, which is called global language score. This is possible to do statistically. Okay, so that is how it was possible. I want you to take a minute and have a look at this, because what dots you are noticing here are those 168 children that got implanted, okay, out of the 472 children. Look at this data, because it says these children were implanted, or the switch on happened at 6 months, this is 12 months, this is 24 months, this is 36 months. 3 years, 2 years, 12 months, 6 months. And it's telling you how they score. So look at this data and can you tell me what is your observation? So up to 1 year it is better, then
After that, it is the language score is going up.
okay, yes.
As the age of activation increases, the global language score decreases.
Yes. Anything else? Okay. So we now see there is like both of them has said 6 months is doing better than 12 months, 12 months kid is doing better than once at 24 months. So we don't need to see children, but we need to see data to believe that yes, intervention at 6 months yields better results than intervention at 24 months. Okay. So you may all say, but we've learned this, we know this. Oh, I mean, what's new in this? But it's also to re-emphasize that it is data that tells us, or the guidelines get formed from such kind of data. Although we may know that early is better, but it's the data that tells us, it's about the evidence-based practice. Okay. Yeah, I think memory was also one of the, it may be one of the things. I can show you something else which looked at memory also. Give me 1 second. Now, look carefully. We were looking so far only at that implanted children. Now, what you see here in green, does everybody see the green area? Those are scores of typical hearing children. Okay. So, what you see in green is typical hearing children. Now what we will do, take a minute and see, compare these scores of the implanted children with the typical hearing children. What is your observation? Correct. So he is saying these kids are almost doing like any other child. What happens over here? They are also coping up. Okay. But as we wait, we know that they are not able to catch up and cope up with typical hearing children. And why do what do parents want for their child? They want, when they go in for cochlear implantation, they want one result, that he should become like any other child. But to become like any other child, we need to get them early. Most of the time what we see, they come to us here and there. Okay. So the point we are making is, we should not get discouraged by this, but we should not waste any more time. If someone has come to you with severe to profound hearing loss at age 2, we cannot waste next 6 months with hearing aids thinking that there will be some outcome, there will be some improvement. We know that with profound hearing loss, they will not be able to have language skills like a typical hearing child. Okay, so therefore this says, don't delay. If we arrest that delay, that will be a big step. That is one of the things that you can, at least is in your hands. The rest of the factors, you can't do anything about it. Okay, so let's look at what he has just told us. At 6 months, the global language score was around 100. And they are at par with their hearing peers, right? Perfect. This is the ideal world. That is why West is 136, because they are doing that. Okay. Now at 12 months, the global language score is at around 90. So it has dropped from 100 to 90. Why? Because the waiting of 6 months, but they are still catching up. Okay. Now what do you expect to happen later on? At 24 months, see the global language score is how much now? So a child is aspiring to score 100, but because of his age of implantation now will score 75, and he is struggling to catch up with his typical hearing peers. However, you see there are still some children who were implanted at 2 years, although majority of the dots are here, there are some children who are here. Why is that? Yeah, this is because the child is either cognitively very sharp, the maternal education might be very, and the rehabilitation might be very good. Others may have help, but it's a very small number of stars. So you will also see some implanted children at 2 and 3 and you say, wow, what an outcome. Could be these. But you can also look at this data at 6 months and also are all the babies doing very well? Every baby should have done well, right? Why is not every baby over here? Yeah, because we looked at some had associated problems as well, right? So they may therefore be, they're still doing better than what they were, but this then represents a true cohort. Then you know that the results are true results because it's representing what is happening in real world. Okay, so what is the message that you take back from here? That whether they are children with or without disabilities, what we will do, early intervention matters for every child. That auditory brain development is key for every child, whether they have associated problem or not. In low-caste studies, 60% of the children did have additional problems. They may do poorer. See, on average, they did lower, but they did better than what they would have otherwise done. Okay, so you might see a child, you might say the milestones are very late or he has associated problem. But remember, it's a sense, auditory input still needs to go in for the auditory cortex. So with other associated problems, this auditory input is as essential even with additional disabilities. Also, you have to also bear in mind that a parent knows their child for so much time. They watch their child or watch their behavior for all the time. So usually a parent can become a good predictor. Sometimes parents can tell you that these are the issues and based on that we can predict how much the child can do. So there is something called parent evaluation of auditory milestones. So that questionnaire tells us what the parent has observed and basis that we can say how much will be the outcome. But use the peach, most of you may not use anything because in very young children you cannot directly check how the child is responding. So the questionnaire becomes very good way to find out if the parent has observed certain things, like if a dog has barked or if a car has honked. So it will ask those questions and they can you can find out a score and understand where that child is performing. So you were asking about memory. These were all the aspects that got covered. So they looked at age of fitting, maternal education, hearing loss, additional disabilities, cognition was one of the aspects that also got looked at. So that once you have such kind of study, you can come out with lot of factors and variables for outcomes. So what do you take back from such a powerful study, which is data at 9 years? So we were talking about 3 years, 6 years. So one thing that you need to remember is, first thing is how early have you turned on the device, whether it's the hearing aid or cochlear implant. Second important factor is IQ of the child. So if you don't know how to do IQ for very young babies, then on the Cochlear website there is integrated scale of development which helps you find out what is the cognition of the child. Okay, so cognitive ability means how is the learning, how is the processing. Next is the socio-economic factor. So usually in lower socio-economic families, the exposure of the child to whether it is even play or even to stimulus will be very, very limited. Versus educated families will give the best exposure, right? So that those are the key factors for outcomes. So what is the success formula? Early intervention, good IQ, good family support, you should get good outcomes with cochlear implantation. That is how you should be aware of. So, like he mentioned, based on this study, the question is how early is early? very early implantation by 9 months of age. So based on what you saw, 6 months, 12 months outcome, 9 months was considered where you can give the child the best chance for developing language and psychosocial skills. Okay, that's the best thing we can do. Why? Because cognitive development, which is the foundation for language. And how is foundation for language developed? Because of working memory. What is working memory? As I'm speaking to you, you are processing that information. You might decide to store it, or you might decide that okay, I have heard it, may or may not require in the future. So that's where we use working memory to store and recollect information. Okay, so these are the fundamental things why early implant will lead to cognitive development, which is the foundation for the working memory part, okay, in children. So you can think of early fitting. So if you are fitting children, don't delay in fitting the stimulation. So hearing aid in children, when you fit, especially in severe to profound, why are hearing aid fit? Because between 3 months to 6 months, because you have identified, you have started the intervention, and between 6 months to 1 year, you want the input to go in. You want that it is a transition device, it's a stimulation. So you will fit the device, because until cochlear implantation is fitted, that's the stimulation. The other reason why you fit a hearing aid is for acceptance. If I don't accept a device, and the third thing is for the bond to form between the mother and the child, because otherwise he is not going to reciprocate to anything. The mother will also not feel like communicating with the child. But look at it as a temporary interim solution, not a permanent solution. But permanent with a cochlear implant. So early fitting, and even with children with auditory neuropathy and additional disabilities. And last is parents know their child, and they, based on what they tell us, we can predict how that child can perform. Like they will be able to tell if there are issues in learning, or they are not able to grasp as per the input. Okay, so any questions on that, and then we will see how much time we have to go to the next topic. All good? Any questions? Can we take a 2-minute break before we start the next topic? So it's 7:15. We'll take a 5-minute break. We'll start in 7:20. Or you need a 10 minutes break? 10 minutes? You want to finish calls and other things? Quickly decide. Should we start in 10 minutes? Is 10 minutes good? Yeah, yeah. And then we'll try and finish by 8 o'clock. We can finish by 8 or even early if possible, if that is okay with you.
How long the next presentation?
We are going to do adult cochlear implant.
Will it take half an hour or what?
Ha, ha.
Hello, hello, hello.
So, do you think cochlear implant is only for children? Uh, that's because I'm presenting, you're saying no. But what is the perception? What have you seen commonly? What have you seen around? Do you see those many adults with cochlear implant? Okay, and very other interesting question. In your own department, how many of your patients are adults and how many are children? Are adults, right? So some clinics, very few have lot of children, but majority of you are seeing lot more adults, right? So that is one of the things. So we'll start with a nice video that shows how cochlear implantation can transform life in adults. Okay, so now let's start with our topic for today. Because you all are getting ready for dinner, right? Yeah. So, what we are going to focus now is standard of care in adults with hearing loss. So, first time we have something called guidelines. That means an adult with a moderate to severe, profound sensory neural hearing loss, bilateral in both the ears, goes to X audiologist, Y audiologist, any audiologist, the standard of care will be the same. So it doesn't happen that he treats this loss differently, that person or audiologist will treat differently. So the first time we have such guidelines and consensus available, and that is why I'm going to share with you what are these guidelines or standard of care guidelines. So for that, I asked you, we started the session. Ask the first question is, in your own appointment schedule, how many adults do you see? And most of you said majority of them is adults. So even in WHO publication worldwide, we see there are more than 460 million people worldwide living with a disabling hearing loss. So it is substantial. There's work for everyone here. Okay, not for one individual or the other professional. Everyone will play a key role over here. That's because 1 in 3 people over the age of 65, because of their hearing loss, their communication is impacted. So be it communication that is leading to isolation and so many other challenges that come with hearing loss. Also, around 15 million people could actually benefit from a cochlear implant or a bone conduction implant. When I talk about cochlear implant, majority of those with a disabling hearing loss are from the Asia Pacific region. So we have concentration of people with disabling hearing loss, and ours being an Asian country, it is quite prevalent here, which you have also mentioned in our interaction. And presently, what is the scenario? Less than 5% of people who may benefit from a cochlear implant received one. Why do you think very few people have a cochlear implant in adults? Correct. So one is because of lack of awareness. They know that it's the limitation of a hearing aid, but they don't know what is beyond. When hearing aids don't benefit, what's the next step? Okay, so it's the lack of awareness, and you are here today to understand that how cochlear implantation can be beneficial for those who don't benefit from a hearing aid. So what I'm going to take you through, it's an international consensus which is called the Delphi consensus, and what it is highlighted, or in this they are international specialists. So it is not created by the West. They are professionals from India, across the world, who came together and said what is important if we start to see adults with bilateral severe to profound sensory neural hearing. And they came up with that the recommendation should be the use of a unilateral cochlear implant in adults with severe, profound or moderate sloping to profound bilateral sensory neural hearing loss. So this is been a guideline set together by experts, and that is now the trend or practices across the world, that okay, with these laws they should be informed about the intervention like cochlear implantation. That is the one step towards awareness of cochlear implantation. Okay. So what we are going to look today is understanding hearing loss and when cochlear implants might help, learn about how cochlear implant system work, and then you are also becoming aware of understanding the cochlear implant journey. What is the first step? What is required from your end as a professional and even for the patient's hearing journey? So this is what we will cover very briefly. all of you are aware in sensory neural hearing loss, when there is loss occurring in the inner ear or the hearing nerve is damaged or does not work properly. So we know that the damage is mostly at the level of the cochlea. Now let's get into a deeper part of it. So what's happening here? So here we know that with higher degree of loss beyond a severe degree of sensory neural hearing loss, you can have a inner hair cell loss function or dysfunction, and that could also be causing from the dead regions in the cochlea. So we know that these dead regions in the cochlea, even if you try some intervention, it's not going to be very beneficial. So okay, so one thing we have to remember, that with inner hair cell loss beyond 70 dB, you might have a cochlear dysfunction. Cochlear dysfunction again will lead to very poor speech discrimination. Okay, so those are the physiological limitations that exist with a severe sensory neural hearing loss. Now, what are some of the challenges that you have faced when treating severe to profound sensory neural hearing loss? So, a lot of you have seen adult patients, but what are some of the challenges you have come across? Excellent. So, first thing he has said, which is poor speech discrimination score. Yes, what else? So, we particularly come across audibility is an issue, correct? So what you try to do is you try and manage audibility through loudness. What happens to the dynamic range in these cases? How much is the dynamic range in a profound hearing loss? Which is narrow is how much? We get a dynamic range of between most comfortable level to uncomfortable level is hardly 10 dB, 20 dB, and that is what is the range that we have to manage. With a 20 dB dynamic range, how are we going to provide the audibility as well as the resolution? The next thing is, we know about the auditory filters. What is happening with severe to profound hearing loss? What happens to the auditory filter specificity? They tend to become broader. Is it narrow, the filters? We know that there are filters, right? Auditory filters for every frequency. With sensory neural hearing loss, what happens to those filters? The filters start to get broadened. Because the auditory filters get broadened, that is where your frequency resolution, your understanding starts to become affected. Okay, so which is what we are not able to manage. And also, we cannot think of cochlear hearing loss as isolation. Anything to the cochlea will now further go on to the nerve and even the central auditory pathway. So you cannot isolate cochlea, and that is why when we write we say sensory neural, because sensory is not limited to cochlea alone. It has its impact through the auditory cortex even at the pathway as well as at the cortical level. So remember, we have two issues. One is attenuation and the second one is distortion components of the sensory neural hearing loss. Attenuation is where it is reduction in sound, and the distortion is whatever you try to do to the sound, it is still going to be distorted because you are trying to put it through broadened filters. Okay. Now, what are the challenges that you as professionals have faced when treating severe to profound hearing loss with hearing aids? What are the few things that you have noticed after you have fitted hearing aids to these patients? So, when you fit with them with the hearing aid, most often there will be saturation. Sometimes you will find that they are complaining it is distorted. The second thing is, you are sometimes not able to give them enough amplification, right? And because they are dead regions and hair cell damage, whatever you do, you are not able to make the sound clarity better. So, even if you make the sound audible, it doesn't mean you can extract information. Audibility doesn't mean you are able to make it intelligible. So audibility is just making the sound loud enough, but you cannot make it intelligible. Okay. So, your patients can't hear with powerful and optimized hearing aids. What do you think, what impact does this have on their health and well-being? So what happens because of that? What do you start seeing happening to them? One is, what is depressed? How, when do you say a person is depressed? Yeah. Correct. So what is he's going to do? He will start to do isolate. What are the other things he starts to do? He will use other coping mechanism. If he has to go shopping, he will not go alone. He will take someone along with him. So they are now trying to cope up in by compensating. That is what you are trying to, you should try and identify that we have fitted a solution, but yet this individual seems is very angry sometimes, very frustrated because he's not able to get through the communication. Sometimes he will feel isolated, he's socially withdrawn. So those are the things we start to see on his well-being. But it is also shown that hearing loss in adults can leave significant impact on their mental, physical and psychosocial stability. And it is also linked to things like dementia and such related disorders. So why should we consider cochlear implant in these patients? What do you think cochlear implant can provide them? Okay, the first important fundamental thing is we know that the loss is severe to profound. What a cochlear implant can do is provide access to sound. So, when you do their aided cochlear implantation, most of these patients, their aided will be above the speech banana. So, they can hear as soft as 10 dB, 20 dB. So, even if you make this kind of a sound, the access to softest sound is also there. So you are trying to improve their severe to profound, which you were struggling with the hearing aid. Now you are able to move them from a severe to profound to their aided coming within the 20 to 25 dB range. Okay. So we will see in some of the cases. So adults receiving cochlear implants understood sentences. Why sentences? Because when we do a conversation, we talk in sentences. On average, almost 8 times better than they could previously with their hearing aids. And we will see how things change with cochlear implantation. I think this video is also something you can watch. So, what we know is average length of severe to profound hearing loss prior to receiving a cochlear implant is 10 to 12 years. So, again, they know that their hearing loss is progressing, it's getting worsened, but they continue to be on hearing aid until they have made a decision to go for cochlear implant for at least how much time? It's 10 years already by the time they come to someone who tells them that there is a cochlear implant as a solution. Okay, so those precious 10 years are gone, but like these people told you, 73% were implanted within 1 year once they realized they were a candidate for cochlear implant. That means they were so struggling so much that when they knew after a powerful hearing aid there is something next, they were ready for it. Okay, so cochlear implant is not the final thing, it's a part of their journey. So you know their journey starts with a powerful hearing aid, then they go to a superpower hearing aid. So instead of going through a series of superpower, at least let them know that the next thing, in case they don't benefit from a superpower hearing aid, is a cochlear implant. Two things happen. They know that they don't have to worry because there is intervention, and they know that they, at the end of the tunnel, there is light, there is hope, there is some solution. And they also say, well, I didn't have to live with that anxiety that what will I do if it gets worsened. They're always worried. What if it gets bad? Because you tell them now it is severe, it has dropped by 5 dB, it has dropped by 10 dB, and they start to worry, okay, what will happen if it gets even worse? Because they know that anyway with the powerful hearing aid they are struggling right now. So remember, again, they are on their journey. It's good to guide them early on. It gives them time to think. We are not telling them tomorrow wake up and do a implant, but it's telling them that there is a solution that exists and that will reduce their anxiety. They will be able to better understand that in their journey there is a solution that exists. And for most candidates, their outcomes with implantable technology exceeds their performance with hearing aids. And we will see some of the data where they are in their existing situation. They'll definitely do better with the cochlear implant compared to what they are presently performing. Okay, why? Because hearing aids, we know, are still making use of the damaged hair cells to produce the hearing sensation. In cochlear implant, you've seen we are bypassing the damaged cells to produce a hearing sensation. The frequency that we are able to cover is as low as 188 Hertz to 8000 Hertz. That is why we are able to provide the access to sounds. So all the link sounds, they have access as soft as 20 dB. So from a profound hearing loss, we have brought them to say near normal hearing because of the access with cochlear implantation. Now we have got their hearing to near normal level, but the brain is hearing the sound in a different way, and that is why we don't need to teach them like children. We just need them to know that sound is new, it is different. Give the time the brain, give time to the brain to understand the new way of listening, which comes with practice. So in our practice too, there are simple exercises which on a daily basis they do for a couple of months. In 3 to 6 months, they are coming back to understanding words and sentences auditorily. They don't have to do any lip reading. So again, for all of you here, acoustic hearing is covering all the frequencies. In cochlear implantation, we do not use the organ of corti, we don't use the basilar membrane, we don't use the traveling wave. We are focused on the spiral ganglion. So spiral ganglion is the potential site for stimulation. So we don't have to worry about the damaged cochlea and the entire organ of corti. We work everything beyond it. So the spiral ganglion is what is our focus of stimulation. And we have data to show that we are born with huge population of spiral ganglion, but even as you age, even if you have a hearing loss, you have enough residual spiral ganglion to stimulate using a cochlear implant. Okay, so like I mentioned, cochlear implants what we are trying to aim is with the implant and through programming, we are now able to move them from 100 to 110 dB, even those with 80 to 90 to above the speech banana. So access to all these speech sounds, especially in adults where they have maximum problem between the 2 to 4 kilohertz. That's where you are trying to adjust your gain majority of the time for severe to profound. If you cannot give them enough gain in the 2 to 4 kilohertz, the intelligibility starts to affect. Why? Because it's the consonants that give you meaning. It's not the vowels so much. So cochlear implants, they will have access to this. Therefore, he said that in that video we saw, whether it's the leaves, whether it's the birds, it's the zipper of your purse, it could be the can of Pepsi that you open, even that hissing sound, so they can appreciate even those kind of soft sounds. Plus you have access to all of these speech sounds which make speech understanding easier. So I think you all know how a cochlear implant works, but it's just good for you to kind of ensure that. So they are the two most important components. We've seen that there is an implant component which is surgically fit in, and it's not the surgery of the brain. So this is placed in the mastoid area, and then you have the sound processor which is fit in externally. So it involves the two components. One is an external component and one is the internal component, and that is how the sound is conveyed to the electrode. Okay, so all of you have seen in that video, the main work is done of picking up the sound. All the processing, whatever job your cochlea was doing, typically a cochlea acts like an amplifier, right? So that job is now done by a sound processor, and the sound processor gets its power from this battery. So it is a rechargeable battery. From then the antenna, it sends a radio frequency. That is why cochlear implant is different to a hearing aid. We don't have radio frequency. We don't have to send the signals through the skin in a hearing aid. Then it goes through the skin, it comes into the internal antenna. So the internal antenna will now feed that information into the electronics. So this electronics is inside a titanium casing, so that the titanium is strong and protects the electronics. The electronics then decides which electrode inside the cochlea, like it's a piano. So which are the most important keys or electrodes that need to be stimulated. And once, if you have the word choice, for example, it will only stimulate the ch, o and s, those kind of elements of speech, and then that information will go from the spiral ganglion to the auditory nerve to the brain. So this is how a cochlear implant works, which is very different to hearing aid, which is more like an amplifier. Here it is doing processing, sound coding, all the digitization is happening within this technology. Okay, so it's no longer an experimental device. Cochlear implants have existed now for last 40 years. So we now know that this is a effective intervention, and you've seen how the whole process occurs, right? So for all of us quickly, we have three key elements: acoustical, electrical and perceptual. In that you have frequency, intensity and timing. In electrical, how is it done? Through the electrode. So you have electrodes that are at the basal end of the cochlea to the apical end. The intensity is when you do programming or mapping, you are setting the loudness. You decide how much charge you need to provide for mapping to give the appropriate loudness, so the patient perceives the loudness. In electrode, the patient perceives the frequency, so he knows this is high frequency, this is low frequency. Therefore, patients with cochlear implant, high frequencies, they will never struggle, which is what they struggle in hearing aids. And then we provide them the timing cues, which is how many electrical pulses per second that you provide. That gives them the cues for duration, the timing cues. So all the three aspects of sound is how this is coded in cochlear implants. Now, very, very interestingly is cochlear implant technology is growing at a very great pace. It's like becoming a revolution and innovation in how the technology is working. So the present sound processor is the Nucleus 8 sound processor. It's the world's smallest and lightest sound processor, because our recipients wear this sound processor for almost for 12 to 14 hours and even longer sometimes. So they need it to be lighter, and the battery runs or helps them to be uninterrupted hearing throughout the day. The same technology is also available in a way in the off-the-ear sound processor. So more discrete solution. And the Nucleus 8 that we have, which is our latest generation, also has the Bluetooth 5.2, which is the BLE audio technology within the Nucleus 8 sound processor. So, lot of innovation happening, like you have been experienced in hearing aids, is also now available in a cochlear implant sound processor. The biggest leap being that even now a cochlear sound processor has the next generation Bluetooth LE audio. Okay. Plus, you can now use a cochlear implant on one side and a compatible bimodal, so they are able to use whatever technology across both the ears, even with the implant and sound processor. When we talk about the implant part, you have the slim modular electrode, the slim straight electrode. Now these both electrodes, this is meant to give you hearing performance, or basically how? By being very frequency specific in the stimulation. So if you look at all of this for an adult patient, whether they want wireless accessories or the app where they can find their own processor, they can do direct streaming, they can use the Apple proprietary protocol for audio streaming, or they can use the Asha proprietary protocol again for audio streaming. So overall, as an adult, they live an active life, everything to suit their hearing needs. Okay, so be it whether they are in a restaurant, be it whether they are in classrooms, or even on the beach where there is wind, you have algorithms for all of that within the sound processor technology. So you can see you have now solutions or choice to give whatever you want, whether they want the off the ear or even the behind the ear sound processor technology. And what is very, very critical is our unmatched reliability. What is reliability? That means how many years that implant can work successfully, especially if you have implanted now, will it last for a lifetime? You are going to counsel them for surgery, you notice that they are taking time to make that decision. So when it is to counsel for revision or reimplant, it is even more difficult. So we want to avoid that situation, and the only way for that is to have a more reliable implant. So when I talk about reliable implant, it's about how strong that implant is over a period of number of years. So our implants tend to get even better and better reliable as we make them new and make them stronger than our previous generation one. Okay, so presently most of our implants have a reliability rate which is in over 90, close to 99%, which means they are strong and durable for our patients. Now comes to the last part of our discussion. What is it that you need to do in a cochlear implant journey? The first thing is evaluation. Evaluation means audiological assessment. What do you need to do to find out whether a cochlear implant will be suitable for them or not? Then the second part is the procedure. The third is the device activation, and then becomes the rehabilitation or the training, the troubleshooting and those aspects. So in evaluation, you will do your typical test battery, audiological test battery, which will also include, if possible, under the headphones, you can do your speech discrimination. For the right ear, left ear speech discrimination, and if possible, then aided speech discrimination. Okay, so to decide the ear, which ear is better, which ear is poorer. The MRI and CT scan, because MRI can tell us the status of the auditory nerve. Status, it is the structure, it doesn't tell us the function. Function will be only by audiological testing and with hearing aid. Okay? And then the CT scan tells you the cochlear structure. Is the cochlear structure well formed or not? Then, as I highlighted, speech understanding, and then also helping, how you saw a video of Sangeeta recipient and you understood what the whole process is. So even a recipient, a candidate, when he meets a recipient, he understands the journey much better. He can relate that I've been through this, what was your hearing journey also like. The surgical aspect, we know now it is becoming easier with general anesthesia, not too long. The surgery typically takes 1 to 2 hours. It is considered the same risk like any other ENT surgery. It doesn't make it higher because it's a cochlear implant surgery. So it's a low risk routine medical procedure. It is established as a non-risky procedure, and the hospitalization period is very short. So you can get admitted at night, get the surgery and get discharged the next day. So it's fairly a quicker, simple procedure. Nowadays, I showed you the implant. The implants are getting thinner. Even the electrodes are thin. So you need only a small incision. Earlier, huge incision, sometimes you would have to have the hair shaved and people would not love that, but now you don't have to shave as much hair, you can have a smaller incision, and like I've said, sometimes you don't even have to shave the hair. And then comes the exciting day. We've actually got a very nice glimpse of what that day is. It can be exciting for some, it can be anxious for some people, because their expectations can be very high. That the day you put in the device, everything should be, like what it was like normal hearing. But we know it's a different sound. We've just seen microphone is involved, sound processor is there, electrode array, then to the brain. So sound is going to be different. So that's your role that you play when it comes to counseling. So if you want, you can be involved, or you can always refer it to some other audiologist. So we can actually monitor how much our recipients use the device. We always encourage them to use their cochlear implant at least 10 hours on a daily basis. And we can monitor how much speech is going in. So are people talking to these implanted patients or not? So that is also something we can see on a Nucleus Smart app. And then comes some nice listening practice, which is very, very interactive. It is not like kids and how you teach a kid, basic vocabulary. It's exercises which are very interesting and based on the level of that particular patient. So those resources are also available on our website. You just can translate it into local languages. With that, I wanted to quickly, at the final stage of my presentation. So referral is for a cochlear implant candidacy assessment, not for a CI. What you need to understand is what the US has now recently done is called the 60-60 guideline. What is it? Because sometimes you must have asked some of your colleague audiologist, then when should I send you for cochlear implant? I don't know. Is this the correct patient for cochlear implant or not? That goes through many of the audiologist mind. The question is, when should I send for cochlear implantation? So at the University of Michigan, this study was done and they identified that first, check the daily interaction. Does your patient struggle on the phone? Do they have difficulty understanding unfamiliar speakers? Have they started withdrawing from social events, and do they need repetitions very often? So one is this checklist. The second thing is, if in their assessment the pure tone average is more than 60 dB. More than 60 dB in the better ear. That means this is my better ear, it should be at least 60 dB. And the worst ear will be worse than 60 dB. Okay, so one ear is as good as 60 dB, the other ear is worst. Then one of the reasons for sending for evaluation, whether they are considered for cochlear implantation, could be this. Okay, so better ear has to be at least 60 dB, the worst ear could be 60 dB and even worse than that. Most often your thought process is 60 dB you will manage with hearing aid. When do they start to struggle with the hearing aid? When they are more like a severe hearing loss. So that's where your speech discrimination will come into picture, because only speech discrimination for one patient with severe loss, his speech discrimination will be very poor. If you have another patient, for him his speech discrimination will be good. So that's why speech discrimination is very important. And you can always do speech understanding, which is called speech discrimination or word recognition. You can do it under the headphone. When you have done your audiometry, just continue with your speech discrimination. Why? Because you can do it at slightly higher level. Once you have done it with your aided, you cannot increase your presentation level. So you have to do it at 65 dB if you are doing it at aided. But if you do unaided, you can still have scope to increase your presentation level. Okay, so that is why speech discrimination is, if it is poorer than 60 dB in the better ear, you can consider to refer. Refer doesn't mean that he becomes a candidate. Now you will do all the investigation and see whether he needs a cochlear implant or not. Okay, so we will quickly see this particular gentleman. We see that he is very active, but has been having this progressive hearing loss for last 15 years. He obtained hearing aids 10 years ago and has been going from one audiologist to another to try to hear more clearly, believing it is an issue with the aids. He has top-end devices with streaming, but still can't hear well on the phone. He cannot understand his grandchildren and he feels excluded during family visits. Okay, he is a bit nervous what to do about it. Like he wants, these expectations are there. So there is client oriented scale of, this is the COSI goals. So of improvement, the client oriented scale of improvement. So this questionnaire with this questionnaire you can find out what exactly your patient wants. What you may want him to talk on the phone, but is he keen to talk on the phone? That is what you can find out. What are his goals that he wants? So once you have done that in this particular patient, we can do this assessment. So you can see the right here, the words, CNC words, which is called the PB word list. He had 12% score. In the left, he had 8% score. So is he less than 60 dB? A 60% score? And what about his pure tone? What do you think about this? If you look at it, what are the two things you look? Sloping hearing loss, very good. Yeah. So look at the previous three things. Go back and look at this list. Do you think these are his issues? Okay, so you now know you have ticked this mark. Now let's look at his audibility. How much is pure tone average? Is it more than 60 dB? In 1 year, both years? Even his better ear is poorer than 60 dB. Now let's look at his speech understanding, unaided word recognition. So we now know it is poor on both the sides. So now you have understood the whole process. What would you do for this patient? What's the next thing? We did audiological assessment. What will happen next? ENT referral, or now you will try and think, is cochlear implant right for him or not? So radiological assessment, so which includes CT and MRI. And then What if he goes with a cochlear implant? So this patient went with a CI622 implant and within the left ear and activated 2 weeks later. So after implantation, he is less stressed at work and managing meetings again by about 6 weeks post implant. He loves to stream off phone calls through his cochlear implant, especially when the office is noisy. He says he would be lost without the cochlear implant now. So where was he earlier? You saw his loss. Now with cochlear implant, where is he? Okay. So he got his implant and you can see on the left what is his word score. So when he was struggling, he was only understanding so poorly, which was 8%. With everything that we do right, what are the things that we have to do correctly? We have to ensure that deprivation is not too long. We don't want people who have very longer period of deprivation, and we should ensure that he is still in the 60s. If we wait till he becomes 70s and 80s, two things will come. Health issues come into picture, processing, cognitive, all those aspects. So always remember what we talk about in children. Early implantation and intervention also matters for adults. The same result he may not get if he waits for another 10 years. Okay. So very classic example of what cochlear implant can change and transform into. We don't have time for this particular case. But overall, what are the things that you can look? Always look at, is there more information you need to make a decision? So what are the common causes for bilateral severe to profound sensory neural hearing losses in adults? Which are the common ones that you have seen? One is age, okay, but let's look at younger adults between the age of 30 to 50. What are the common cases that come to you? Noise exposure, yes, but noise exposure, you will start to see high frequencies dipping, the lows still take time. Drug induced, very common, and no matter what you do, their discrimination will be very, very poor. So ototoxicity, if you have any cases of ototoxicity, please ensure that you have discussed this, because their whole life, quality of life will change, because with hearing aid it's going to be very difficult. So which is the other age, which are the other etiologies? Ototoxicity, very good. Autoimmune disorders where there was sudden sensory neural hearing losses. Chronic suppurative otitis media, which has been long standing. They have been having as young adults, then they are 40s, then they are 50s, and then suddenly they have lost, it has become SN. Cochlear otosclerosis. What happens in cochlear otosclerosis? It starts as conductive, becomes mixed, SN. And what happens to their speech discrimination? Poorer and poorer. So, very classic. Cochlear otosclerosis. The ones that were conductive and mixed and now have become sensory neural hearing losses, they fly off with cochlear implant. Why? Because they never had a sensory neural element for a long time. They will be the fastest and best cases to do. So, if you have cases who after surgery lost their whole hearing, whether it is with CSOM or even after otosclerosis, failed surgeries where now they have sensory neural hearing losses, be it severe to profound, they are best. Progressive hearing losses, you have fitted when they were moderate, then they become moderately severe, they can also become good candidates. So many years, progressive hearing losses, these can be very good. So this young adult group, if they get implant, they can go back, they will earn and they will be able to support their family. They don't have to depend on the family. Okay. And most often funding is not so much an issue for them, because nowadays there are a lot of organizations who are willing to fund their own employee, because that employee is very adds value to that organization. So there are some insurances, there are some organizations, there are some employee funds that can be available. So that we can definitely help and find out. So don't think Oh, what about cost? That is secondary. He is looking for solution because his whole life is going to be changed. He is not having to restricted in his promotions. He doesn't volunteer for certain things because he feels limited. Those things is what you can change. And what he will do, if he is happy, he will motivate other patients. And if he is unhappy, he comes back to you, you will see him coming in, you also feel what more can I do for him. So remember, yeah, he's smiling because he can think of such patients. Because some patients we really can't do much, right? And we want to have patients who are more happy, satisfied. And if what we want to do is at the end, everybody gives the same message that think of cochlear implant, he will think about it. But if 10 people tell him hearing aid and one person tells him cochlear implant, he is going to say the 10 people are right. So therefore, as a professional group, we all need to understand that at least for severe to profound sensory neural hearing loss, we need to inform them that there is an intervention like cochlear implantation. Whether they proceed with it or not, ultimately is for them. But we need to start at some point, otherwise it is going to make very difficult for the patients also from a progress perspective. Okay, so I think these were the cases, but we may run out of time. So I think we took this case example, which was good. And one last thing I would like to show you here, that most of you are thinking, what are the results I get from cochlear implants? This is again data, like I showed you the loci data before. Monosyllabic words, why do we take words? These are the hardest. If I talk in sentences, you will do guesswork. So hard, you take words, you see with hearing aids, they get 0 to 10%. What do you see with cochlear implant? On an average, they will at least do close to 50 to 60%. Okay. So this is where we have seen huge benefit in terms of cochlear implant. And you don't have to worry, because if they have good hearing on the other side, if we keep them on 2 hearing aids versus moving them to 1 hearing aid on one side and 1 cochlear implant, you can see understanding in small group improves from 8% to close to 80%. What is the second need of adults? TV, they were 13% when they were using 2 hearing aids. Now with 1 hearing aid and 1 cochlear implant, they are at 80%. So he comes back happy to you because he is knowing I'm able to make use of both the hearing aid and cochlear implant. Music and noise, again we see that it is close to 60 and 70%. So this is again proven data that adults with 2 hearing aids would have struggled. Now we can give them the option of 1 hearing aid and 1 cochlear implantation. Okay. So I think this is what I wanted to highlight, that there is enough data to show how cochlear implants help, and early we do, the better it is. So that is all that I wanted to share with all of you. Do you have any questions about any thing that we discussed so far?
Madam, you have said 60 dB. Which year would we select?
Always remember one thing, that if that ear is audible, we make it audible and we do speech discrimination, and if it is good speech discrimination, we will always keep the ear aided. We are looking at the ear where the speech discrimination is poor. How poor are we looking at? We should at least look at anything between 40 to 60% discrimination, because while I am talking to you, if you understand only 50% of what I am understanding, that means the rest 50% you are having to do guesswork. So, yeah.
One question about speech processor.
Mhm.
As we have different parameters in hearing aid to filter noise, enhance the speech,
Okay.
do we have the same in the sound processor?
Yes. So for that I can play a video for you if you are okay, if you have another 1 minute or so, which will tell you what technology is there inside a sound processor. Give me 1 second. And it is good for you to finish this session also. Okay, with that, thank you so much. You're being patiently sitting for extra 30 minutes. So,
Same explanation was done by Shiva last class.
so you got a quick glimpse of what we came and
My question was,